Welcome to Global Dispatches, a podcast for the international affairs, foreign policy, and global development community, and world news aficionados of all stripes. I'm your host, Mark Leon Goldberg, editor of UN Dispatch. Enjoy the show. The practice of global health today can trace its roots to colonialism. It was a combination of imperial ambition and white supremacy that inspired what was known then and is still sometimes referred to today as tropical medicine and hygiene. As my guest today, Ashti Dubey-Persad, explains, the colonial roots of global health are very much still present in many aspects of how global health is practiced today. This can be seen in a variety of ways, ranging from how funding decisions are made to how medical students are sometimes trained. Ashti Dubey-Persad is an assistant professor of medicine and medical education at Northwestern University, where she co-directs the Center for Global Health Education and is the faculty director of the Master of Science in Global Health program. We kick off discussing the colonialist history of the practice of global health and how that legacy is experienced today. We then have a broader conversation about what can be done to decolonize global health, including the role of academic institutions in this effort. Today's episode is produced in partnership with Northwestern University's online Masters of Science in Global Health, which has been a longtime partner of this podcast. You can learn more about this program and how the online Master of Science in Global Health program at Northwestern can help you make a meaningful difference around the world. Visit sps.northwestern.edu/global. And now here is my conversation with Ashti Dubey-Persad.
So, I think maybe, Mark, we should start with the history of global health, or what is global health. And so global health was really born from tropical medicine and international health. And tropical medicine and hygiene was the term used by colonizers to describe medicine in many of the colonies. So what do I mean by that? Essentially, colonizers wanted to make the settlements safe for themselves. And so when they went there, they did a couple of things that really sort of structured the health systems there. Their interventions in colonized spaces were really about the health of those that were colonizing, so themselves. And then also they used health as a tool for subjugation. So they used Western norms of health as a way of describing racial inferiority. There are some advertisements and sort of descriptions of what the white man's burden was in those times. And it was really to teach those and help those in colonies learn about things like soap and cleanliness, and that there was a moral burden or a moral imperative to teach those who were inferior about ways that were superior, all framed in the terms of disease.
That's fascinating. In your answer, you have taught me why the London School of Tropical Medicine and Hygiene has its name. As long as I've been doing this, I never quite got it because it sounded so awkward, but it was born out of that imperialist mindset in which you got to, make the natives clean in order to make it safe for yourself to extract the wealth from the places that you're going.
Exactly. And I'll tell you.
And it's Mark, so weird that school still has that name, I suppose, now that you're giving me the answer to that question.
So like nail on the head in like the first 2 minutes here, because I can't even manage sometimes when I'm asked to work in certain spaces. I've pushed back in a couple of places to say, ASTMH, that's the American School of Tropical Medicine and Hygiene, LSTMH, London School of Tropical Medicine and Hygiene. So how can you go on perpetuating this sort of like parasitic, unhygienic perspective of the world in your name when your purpose is equity and justice, right? Like, talk about the irony. So I've asked, I've been shocked, and I've said, like, how is this okay? And they said, well, we've had some conferences to talk about changing our name, but then we said no. And I said, oh, well, this is pretty bad, right? Because you know what that means. So my family's from Guyana and Suriname. I'm a diaspora Indian, but essentially, like, you just denigrated anywhere that's tropical, quote unquote, as being a place that like needs to be cleaned up, or someone who is superior can come and help those, places of denigration. So the other part of it, have you heard of Gorgas?
No.
Gorgas. So he's a father of tropical medicine and hygiene, and he was the head of the AMA. And there's a headline from the Journal of the American Medical Association, JAMA. I might need to fact check this if this exactly, but he's quoted as saying, when they're working on the Panama Canal, he's quoted as saying, essentially figuring out how to cure yellow fever or remove mosquitoes or remove parasites from this place, removing this vector-borne infection is going to like lead to the conquest of the tropics for the white race. That's the title. It's like 1880s. It's 1909 or something like that. And it is the title.
So if those are the roots of the concept of global health, making the tropics cleaner and safer for white people to conquer, what is the legacy of that sort of mindset in today's architecture of how global health is structured in terms of like large foundations and NGOs? Do you detect a legacy of that origin story of global health and how today's global health system operates?
Absolutely. So that's the issue, is that the sort of legacy and structure of global health really was born out of this colonial medicine, missionary medicine, tropical medicine origin and structure. And so it turns out that power and privilege paradigm is what most of global health is built on. And I will take a moment to say that, there's like a deep contradiction in the work, right? Global health, as we see it today, as we practice, is born out of these traditions and these roots, but our goals are equity and justice. So there's like an inherent contradiction and conflict that I think we all need to recognize. And even the definition of global health has sort of superiority, inferiority assumptions, and we can go into that. But to answer your question, so what it is now today is this. It's similar in that all of the funding structures, the donor priorities, the leadership, the data and the research, all of those priorities are set by the neo-colonials, those with power. Recognition and sort of like even identifying what the critical perhaps interventions are, or even critical areas that require intervention is set by the high income countries, set by the agenda set by those who come from the places that colonizers come from.
Because, say, USAID is the single largest global development funding organization around the world, or because, say, the Gates Foundation is located in Seattle, or what used to be called DFID, the UK's foreign aid arm is a large and powerful arm, because these are all still, the power still resides in the West. It is their priorities that are reflected in global health.
Absolutely. And it's sort of like this supremacist way of seeing and doing things right. Like, just like you said, the USAID office or the Gates Foundation located in Seattle or located here, they are more important, right? Like hierarchically, they are supreme in the global health agenda because they get to decide. Their headquarters are more important than the small local office in wherever that actually understands what the problems are or is engaged with the community or understands the space, because that's where the money comes from. And ultimately, we can talk about sort of we're going to talk about mitigation, but ultimately, if you really think about it and you just go all the way back, it starts with poverty, right? So we talked about colonialism, like the two main sort of tenets, or what they wanted to do, or goals of colonizers is to extract wealth and subjugate, right? So it's power and money. And so if you go all the way back, you're like extraction of wealth, so poverty. Well, poverty begets illness. The countries we're talking about are mostly categorized as lower and middle income countries. Why is that? Because of poverty. Why is that? Because all the wealth that could have helped mitigate much disease and illness, or perhaps build systems, was extracted so early on. And so that poverty begets illness cycle that everybody knows about, right? Like, I think that's the one thing everyone knows, right? Everyone knows that health and wealth are inextricably related, that poverty is like the major social determinant of health. Well, that was created by this system, right? So that colonial system we created is the one now we're aiming to mitigate.
Is there like a specific example of a program or, something that happened in global health in recent past that reflects this kind of colonial mindset?
A concrete answer is what defines sort of voluntourism or medical tourism. I think I'll move outside of in the medical world. What that means is medical students or volunteers or untrained professionals going abroad, or going to an unfamiliar setting and performing procedures they would not otherwise be allowed to do, or that they are not trained to do, or without any supervision.
Like a dermatologist going to like Uganda and performing heart surgery.
Yeah, I'm like so trying to be so careful not to give the glaring examples, because they sound exploitative, but I'll tell you what it is. It's like when so many people in so many places I've been to have asked me to deliver a baby. I've seen many students come back and be excited about trying out procedures they've not had a chance to try before. The notion of, well, something is better than nothing on, quote, these people, unquote. Yeah. So that so people will say, now I want to be clear that young people today, their eyes are open. So 10 years ago, this was more of a running theme, and that sort of superiority thing, like, I want to try. This was a great experience. I got to do an appendectomy and I'm a medical student. You don't hear that as much anymore, but it's that current, right? It's that idea that brings up a lot of questions in education and sort of purposes. What is the purpose of a international exchange? And, I got into the field, or I got into global health ethics and education precisely because of this. So I was asked to perform outside of my scope of training a number of times. Some things were simple as suturing up someone's thumb. So someone who had a machete cut, I was just asked to suture up their thumb. You can probably hear from how I speak that I'm very careful about what I do. And I think a lot about the words that I use and about what I'm going to do, because I don't want to make a mistake. I've never sutured anyone's thumb. I've done some simple suturing. Prior to that experience, I had not done it. So this is someone's thumb, and their entire job is using a machete outside. And it needed work, and I needed to make sure that there were no tendons ruptured. I didn't know what to do. There was no one else there. I ended up spending most of my time figuring out how to get someone who had any surgical experience to do this for me. That's one small example. I don't want to use the big glaring examples when I've seen someone like be asked to do an LP on a baby, a lumbar puncture on a baby, and they'd never done it before.
You have all these examples of voluntourism, plus this idea of donors in Western countries setting global health priorities and agendas for places and countries far away in Africa or in Asia. In the midst of this all, we've had this COVID pandemic, which has upended how global health is done in terms of, sending people around the world, as well as upended in general the global health space. And, it's been concurrent with this pandemic that I have noticed an uptick in conversations around decolonization and decolonizing global health, decolonizing global development. I'm interested in learning from you how COVID-19, how the pandemic has impacted and influenced some of these debates that you've discussed.
Yeah, that's a great question. So a little bit kind of back to what we were talking about, the paradigm had started to shift, right? So people like me, global health educators, have been teaching about humility, about introspection. Most of my classes are on colonialism and on like an entire class on imperialism and colonialism and influence in mitigating voluntourism. A lot of folks have been restructuring programs and thinking about how to do this kind of going forward. But as you said, a lot of the structure of global health involved travel, right? So this idea of parachuting in, the structure of the work itself lends, is this sort of same colonial structure where some, global north, quote unquote, superior university comes in to global south and sort of tells them what to do, as well as in education. Like, much of the global health educational work has been around international exchanges. So what happens when you don't travel? All of us had to really take a pause and say, okay, why do we travel? I've always used, there's a nice global health definition that says that, and I say it to my students all the time, that global health is not about, the global in global health is not about location, but it's about scope of the problem. And if that's the case, then you don't need to travel to do global health. You need to work in spaces that have a global scope that affect health. And so the most concrete thing for us has been reducing travel. And so it's been really helpful structurally to go to our institutions and pause and reflect on why we do this, like a real reckoning on the finances, how much money we spend, cost, carbon for travel. What are the real benefits of the travel? Are they actually moving us towards any kind of sustainable solutions where, ideally, right, in global health, ideally, the way I understand it is you disappear, right? You facilitate and you disappear, because that, it's not about you, it's about the local health system.
The work your way out of a job kind of thing.
Exactly. You shouldn't, if you're still there after 10 years, 15 years, you need to think about, what am I doing here still? Like, why is it that I am here? And if traveling is not the pivot point, right? If traveling is, so what is the pivot point? What is the benefit? Where is the transformation? And so I'm speaking from an educational perspective in terms of transformation. And so it helped a lot of us who've been of this mindset sort of pause, reflect, and kind of push back. And so we've seen a little bit that, like, a lot of the agendas that we wanted to, that fit the quote unquote decolonizing, or perhaps a nicer way is this sort of like anti-racist or anti-supremacy or anti-colonial way of thinking, have we've been able to do that or examine it. So we've been able to examine what happens in virtual collaborations. We've been forced to kind of say, okay, actually, let's see if we can turn this like in-country experience into an online experience. Like, what are the benefits there? Like, who's really benefiting? And we've been able to sort of do things like move funding from travel to local partners, because that's really how structurally, that's how you can make more things happen and make them happen in a way that's really partner driven.
And it's just interesting, like along those lines, what I've heard from talking to people in other parts of the global development space is that, the trend had been towards localization, or at least that had been the aspiration. But COVID-19 has made that a reality where these large NGOs can no longer parachute their people in. So they actually have to rely on local partners to do the job. And many of them are realizing that they're doing it a far more efficient and effective than what parachuting in might have produced.
It's really wonderful, right? So it's like, it's given us a chance to put our money where our mouth is. Like, I'm someone who's always been saying, you don't need to travel to do global health, right? But when I write my educational work, or I spend all of my time, most of it, around the idea of travel. I spend time on partnership and collaboration, but that's specific to all different relationships, right? So even the approach to pre-departure preparation is very general, but actually is about hyper-localization. It's about radically shifting both the listening and the outcomes to our partners on the ground. And I imagine it's making many people uncomfortable. But what's going to be really important after this is that metrics change. And that's something I've been thinking a lot about. Metrics of success are defined by high income countries.
Just having covered this space for, the last 15 years, covered global health and development, there is this like tyranny of quantitative analytics that seems to dominate a lot of the major players. They demand outcomes, like measurable outcomes on specific data points, when in fact, sometimes the actual outcomes are not quantitatively measurable.
It's all about volume. It's not about value. So I was thinking about this, and I was thinking about how, businesses have to fund things that have key performance indicators and outcomes. And why do we have social spaces and government? It's to fund these long-term, like health or horizontal, systematic community building, the real stuff that you can't measure because it takes too long to measure it. That's the space that we need to be working in. And we need to be taking the lead from our partners. I don't even know what my partner's ideas of success would be, because their entire educational and health systems are also built upon colonial systems, predominantly British systems. So for them, even, the indicators that are embedded within their systems are colonial. I'm actually too embarrassed to even ask my partners what they think about the word decolonizing, because I think in and of itself, it's pejorative. So I struggle with even using the word. It's like, why do I have to come in and decolonize? And now it's another supremacy space. And so I was going to ask my partner about it, who I work with in Nigeria. And then I said, I'm too embarrassed to even ask her like what she thinks about the word.
You are in an academic institution. What role do academic institutions like Northwestern serve in sort of advancing this debate?
So we should be really upending this structurally, right? We should be saying to ourselves, okay, we've recognized the sort of pathologies here, the way that research is done, the way that students pursue these exchanges. We need to re-examine that structure. And I think we need to change our measures. Students don't do these like 4 to 6 week clinical electives in an unfamiliar setting where they may not have the skills, supervision that is expected, where we ask our partners, what is it that you like about our students coming? What is it that actually benefits you in the space outside of maybe the tuition? So rethinking that and really rethinking that engagement. So we teach our students what we believe, that's not the way to be. And we need to change the paradigm in the academic space in the same way. So just as it is in the NGO world, it is in the academic space. It's about volume. How many students go abroad every year? How many places do they go? I've always said, be wary of places that have many, many, many pins in their map. Mm-hmm. They go to many, many, many places in the world. And I haven't gotten the analogy right, but it's not the number of pins, right? But it's like the depth of the pin, or like how long the pin has been there, or whatever, that the pin is actually put there by the partner or something like that. But it will require this big shift. I think it even might require renaming, right? If we're saying global health has been about parasites and parachuting, and we want to change that, and we want to be about equity and justice, we want authorship, first author and senior author, that's a big deal in academic space. Maybe you should only get funded, or you get preferential funding, if you show that your first and last authors are your colleagues, where the research are from the colleagues where the research is being done, where the work is being done. How about if you're going to apply for a grant, that the senior PI, principal investigator, must be your partner equally to you. Publications is a big part of it too. So all the journals that are like, the most coveted journals, they're all located within high income countries. The university you want to partner with, we need to change it so that, universities where the work is being done are as highly regarded as the universities here in high income countries. So we've already started ways forward. Like I said, all the classes I teach are about this. So at the very least, eyes are wide open, and there's a critical approach to the work and a critical understanding of some of these social contracts that we've been kind of buying into, or financial contracts. What would be great is if there was a shift in donor priorities also, really, to say, like, show us value, figure out how you describe value. Does that mean that it needs to be a qualitative, I don't know, I'm making something up now, but like that your partner qualitatively somehow describes trust and partnership, and like there needs to be a reckoning with the way we give out money and reparation, right? So I started this by saying this started because our colonizers took wealth away, took money away, began the poverty illness cycle, and then perpetuated it, right? Like continue to take diamonds, continue to take gold, continue to take tea, continue to take coffee, people, etc. I don't know who can quantify that money that needs to be paid back. But as I was thinking about it, well, that would be the first step. Forgive debt, IMF, forgive. Just, and I know there's a lot of talk about quote unquote giving money, right? Like, oh, this is going to happen. That's going to happen. Well, you took money so long ago. So at least give it back.
Well, Ashti, thank you so much for your time. In this course of this conversation, you made me understand why over the course of like 15 years that I've been covering this, I keep encountering solutions to problems that don't exist. So thank you. This was very, very helpful.
Thanks so much, Mark. It's such a pleasure to talk with you and get to talk about this important work in global health.
All right. Thank you all for listening. Thank you to Ashti Dubey-Persad. That was absolutely fascinating. It really did make me think of the practice of global health in ways that I hadn't really understood before. So thank you. And another big thank you to Northwestern University's Master of Science in Global Health program for supporting this episode and for being a supporter of this show over the years. Again, visit sps.northwestern.edu/global to learn more. You can also send me an email, and I'm happy to put you in touch with the good folks over at Northwestern. All right, we'll see you next time. Thanks. Bye.